I don't know why, but they just really seem to like the lower extremity stuff, right? So let's put you in supine. And I'm going to start with this one really because it just, gosh, I think this one was one of the first ones that you probably were exposed to anywhere in the program. But it's called a Thomas test, right? And what Thomas test does is, go ahead and come slide down for me. A little bit more. Just get your knees bent. There you go. Now lay back. The Thomas test, and maybe you remember this, maybe you don't, but this was probably one that you did come into contact with. And the Thomas test, what we do is we do a single knee to chest, basically, with the patient off the end of the plinth. And so literally you got to take that to your chest. Now, okay, so what we're going to do is say, take your head and put it back here. Now, just pull your knee to your chest and let whatever happen, happen. Come on. Pull it to your chest. Now, what you see there is, I'm going to let go here. You see, I could drive a truck underneath this. Okay? What that tells me is, just try to hold that and relax. Really, I mean, pull it back there, hold it. Now, what that says is, this tissue right here is tight. So again, we talked about tissues being, for lack of a better word, torn. We look at symptoms being reproduced. This test looks at a tissue being tight. So Thomas is tight. Hey, guess what? Tight what? Hip flexors. Yeah. And you can really dig into this test too. If you were to flex that knee more, right, you would probably see a more of an increase. So it's really paying attention to the rectus at that point. But just at this point, it's looking at the iliopsoas.
Hey Ryan, do you have an anterior pelvic tilt?
I don't know.
Is that like a way to like find
In this
out?
case, he would probably be more of a posterior pelvic tilt. Just because as he pulls up, he's going to posterior pelvic tilt. If he did anterior pelvic tilt, it wouldn't be much of one because of that tight hip flexor. The iliopsoas and the rectus are going to dictate what you can do on a pelvic tilt. So now we're getting deep. Not that we shouldn't, and not that you're not ready for that. It's just we're jumping in off of stuff from yesterday that's just all bringing it in, right?
He said iliopsoas and what else?
Iliopsoas and the rectus femoris are your hip flexors. Right, so in Kendall's sick, demented game the other day, when I said list 2 muscles that perform hip flexion, you could have written iliopsoas, rectus femoris.
I put psoas minor and major.
Cheap. Iliopsoas, that's my favorite muscle. My favorite muscle. It's also my favorite muscle to remove out of a deer and never let it hit ice. I just rinse it off. Let it cool as it does.
Eat it raw.
And it, well, I can't do that. It comes from a very precarious area. It's got to be washed.
Right in the field.
And cooked. I just do. All right. So that's on, I actually skipped over. That's on page 100, and then you can go backwards. Then we can jump into some of these others. First of all, Eli's. Eli's is performed in prone. So go ahead and pull over on prone. Again, this is a muscle tightness test, Eli's is. And all you do is you take and you flex this knee. Now, if they have super tight rectus femoris, what's going to happen is their hip is just going to kind of rise up, right? And that pays into that pelvic tilt issue. But what we're doing is we're flexing here. And if they have a tight rectus femoris, it's just going to raise up. And so you'll kind of lock out, and as you continue in, it'll just go whoop, right? So that's an Eli's test. So here's what I do, is I think, okay, as they're applying, think about the picture. Let's put this in test mode. The examiner is passively flexing the patient's knee in prone. As the examiner continues into flexion, the patient's hip begins to rise off of the table. This would be indicative of tightness. Also, they may use contracture in that statement of what muscle. They're probably not going to say iliopsoas, but they are definitely going to look at the rectus. Now, the reason they're going to look at the now, if they throw iliopsoas in there, it's because they're really being nasty, and what they're doing is they're testing you on the best answer, right? The best answer is rectus femoris because the rectus femoris is being involved the most. Are you following? So you got to be really cognizant on, okay, Kendall said these both do hip flexion. The hip is coming up. I know it's a hip flexor. What do I go with? You go with the best answer. And then that is because of the rectus involvement as we passively flex the knee. They love to do that to you. They love it. They're going to snap every barrier to trick you, right? Because they want your money. Next is the Ober's test. Ober's test is another tight muscle. Go ahead and side lie for me either way. All right. So on Ober's test, let me just make sure they do it this way too. Yeah. Okay. So Ober's test is looking at a tight TFL. So the patient is sidelined, right? And let me just say this too. Sideline for patients many times is a modified supination. So you literally have to go sideline. And they go, I am sideline. And you're like, no, sideline. Right? So, or it's a modified prone. I am sideline. No, sideline. And so when they do that, what we do is we take and then we lower the upper leg and we see if that knee gets down pretty low behind the other knee. And if it's a tight TFL, what will happen is when you let go of this leg right here, it'll just kind of suspend. And this he's in pretty good shape. Okay. And what I'll do is I'll sometimes hold the knee in flexion. Does the book say hold the knee in flexion at all? Okay. Hold the knee in flexion and see what happens. But that knee should come down a little bit more. Sure. I want you to do it this way. Okay. So again, I just kind of get them in the sideline, and then I flex that knee, and I see where it lands. Okay. Again, I'm just looking at the TFL. That's Ober's. And listen, I got nothing easy to remember Eli's, Ober's, or Thomas. But just kind of, again, what tissue are they testing, right? That's what I see most. I don't think they're going to ask you a name, but I can't promise you anything. I think they're going to hit you on tissue. The piriformis test, it says the patient is positioned in sideline with the test leg positioned toward the ceiling and the hip flexed to 60 degrees. The therapist places one hand on the patient's pelvis and the other hand on the patient's knee while stabilizing the pelvis. The therapist applies a downward adduction force on the knee. So, go ahead and come back to supine for me. So supine, does it say hook line?
Sideline.
It does say sideline?
Mm-hmm.
Well, there you go back to sideline. So here we are with our patient sideline with the affected leg towards the ceiling. And then the very next step it says flicks the hip to 60 degrees. So I'm gonna say that's roughly 60, 45 would be about right there. So I'm gonna say about 60. And then we're gonna say the therapist places one hand on the patient's pelvis, the other hand on the patient's knee. Pelvis, knee. Now what command do I give?
Push up.
So you come up here. Okay. So that is the piriformis test. I honestly never used that one, not one day in my life. But it would be a what? Strength test at that point. How did you test the piriformis for strength in Bill's class?
Down, down.
No?
I don't know if we done the piriformis.
So there you go. Let's do this one. Go ahead and, oh, I do like this one. I'm not sure why they call it the tripod. I never did understand that. Go ahead and flip over to supine. Bring legs down this way. And lay back. All right. Tripod test. We're looking for hamstring tightness here, and you'll actually sit up. I'm sorry. Sit up for me. And the knees are probably flexed a little bit more, closer to 90. And what happens is when I lift this up, do they lean backwards? And that's a positive tripod test. In fact, kind of a unique thing. I've got a patient who I do long arc quads with. And the way we do long arc quads is we lean that patient back against the ball here because the hamstrings are so tight that he can't do long arc quads from an upright position like this right here. He said that really causes him to have some low back sciatica kind of type pains. So what we do is we lean him back, and that's another verification of a tripod sign right there. But they will lean back, and typically when they do, they'll put their hands back as you continue to raise them up. But that's a hamstring tightness test. One more for the hip that I do want to cover. Go ahead and lay all the way back for me. You're going to see this one again on Monday when we cover the SI joint. And it's called Faber's. Now just follow me here. You do a hip flexion, abduction, external rotation. That's known as a figure 4, and that's also another test name for it. It's also known as Patrick's test. Again, this is largely why I don't think they're going to hit you on names, because there's other names associated with. But what you're doing is you're putting one hand on the ASIS, one hand on the folded or flexed knee that you're involved with. And what you do is you compress both sides. That got him.
I didn't know you were going to do it like that.
Well, if I told you, you wouldn't have left me, right? And so you compress, and what you're doing is you're assessing for SI joint pain. And if they have positive pain on the folded side, and I'm going to say this again on Monday, so just forgive me, then it's positive, and it's in the back at the SI joint, it's an SI joint dysfunction. If they have pain in the front, did that bother you in the front?
Yeah.
Then it's a joint restriction, meaning the hip is tight in the front. And we could do some things to mitigate that through our therapy, and we'll talk about that when we get to hips. Okay? That's a Faber, also known as Patrick, also known as figure 4.
Faber is an acronym.
Faber is an acronym.
Flexion, abduction, external rotation.
Yeah, and in fact, you're going to see that as early as next week when we get into the shoulder. And when I reiterate passive range of motion specific to the shoulder, I'm going to say, and isometrics, I'm going to say, remember your Faber. Do it in flexion, do it in abduction, do it in external rotation. Like those are like That's kind of a really common theme you'll see with me and the way I do isometrics of the shoulder and of the hip. All right, so let me talk the knee. So come on up here so you can see these. Go ahead and slide up for me. I mean, just leave your book and or whatever, come to me. All right, for the knee, almost always I would have you laying down, but I want you to see this, so stay sitting. For the knee, again, it goes to varus valgus, right? So valgus, distal segment moves laterally, and so you're applying a force like this right here, and again, you would see kind of in a test scenario, an arrow going this way, and an arrow down here going this way, out. So just kind of remember your valgus definition. Distal segment of a joint moving laterally, valgus. Valgus stresses the medial ligament, right? Just like in the elbow, same thing. So the medial collateral. The thing is, in the knee, you're going to hear this very commonly, and possibly on the test, it would be referred to as a tibial collateral, right? Because of the tibia, right? So here it is. A varus test, right? And this one you'll actually see, when you perform this one, you're going to see a little bit of a hinge because the LCL has quite a bit of play in it. And so here it is, the varus test, the lateral collateral, also known as the tibial collateral. And see how it hinges, right? And that's very normal play. But again, an arrow going this way, indicating that I'm stabilizing, an arrow going this way, indicating that I'm moving in an open kinetic chain. That is a varus test. For the ACL, the anterior cruciate ligament, it gives us a couple of tests. One is more specific and sensitive than any other, and it has the highest ratings, and that's known as the Lachman's test. Lachmans, apostrophe S. Lachman's is a test sequence, and you're going to have to lay back for me to actually get this one on you. Where the examiner will do is they will externally rotate the hip just a little bit, kind of poking the patella at face level. I'll stabilize the femur, and then I take the tibia with my other hand, usually my inside hand, flex the knee just subtly. Feel it? That's your ACL.
Weird. That feels really weird.
It's nice and tight, baby.
Good.
Yeah.
That's still working.
Can you do that tomorrow? Oh, we about to do it. I swear my ACL's gonna break eventually. Just feel like
Any
this.
second.
Optimistic, huh?
No, pessimistic.
That's sarcasm.
No.
Okay? And it really takes, that one takes tons of practice. But once you get proficient at it, like, I don't know if you noticed, I had his foot like kind of kicked off the side here. And Bill noticed this one day. He was like, why do you have his foot way off? I said, it's just how I do it. And he was like, let me try that. And Bill, who is far better and more proficient at any of these tests than I am, listen, the guy is good. And he grabs it and he says, man, I like that. You know, so you can treat your old dog new tricks, I guess, but you know, and that's with your foot propped fully, right? But bam, 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 and you can feel it, thunk, 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 thunk. And what's happening is you're taking the slack out of that ACL, right? And the way it runs. But it takes just this subtle little, you know, twist here, do this, and then pull for the ACL.
So a positive one, it would like come out farther, like distract farther, is that what?
Yeah, and that's why I need Jared to come in. I need you to see, because I can take his, and when I go like this, you see the whole tibial plateau just displace. And really, once the ACL tears, the only thing holding it from complete full forward falling is the PCL kind of catching up slack in the back. And and honestly, you get that true empty infield, right? Because it's not there. And what you end up with is a empty infield, but it still would, some would say, a firm infield from PCL and the hamstrings coming in the back and slowing it down. That's all you've got holding that knee in place. That's why we have to fix them, because there's just, the knee is basically going whoosh every time a person walks. The tibia can displace large amplitudes forward, and eventually that's going to cause a meniscal injury and osteoarthritis and things like that. So they have to get them fixed. But then there's a lot of people who don't. They just go their whole life without them. All right, so the sequence again: valgus, looking at the MCL; varus, looking at the LCL; a Lachman, looking at the ACL; and also there's a test known as an anterior drawer. All right, so just like a drawer, and basically the examiner, I'll literally sit on the foot. I take a flexed knee, looking straight at me, and I get behind it and I open like this. And again, I'm looking for the ACL to not be there. And what will happen is that tibial plateau will go whoop, way up. They also have a PCL test, which is known as a posterior drawer. And I take and I push to see if the PCL is intact. Your book also mentions a extremely technical test called the lateral pivot shift, and I'm going to tell you something. It's extremely specific to the ACL, but a person who has one either has to be extremely deficient and relaxed, or they have to be under anesthesia. And if you see an ACL reconstruction in the OR, this is what you're going to see the doctor do after they get them out. They're going to grab and they're going to put them in this position right here. They're going to internally rotate and flex. Actually, they're going to externally rotate and flex, and then they're going to internally rotate and extend. And what will happen is when they get to here, they'll do a quick bounce, and you'll see that tibia go whoop, and it's like it's violent. That's just the best way I can say it. But and I would recommend watching a lateral pivot shift on YouTube, and especially if you see one in the OR, and you'll see the doctor. They'll just grab them and they'll just bounce that dude, and you can see it just nearly dislocate. It's incredible, especially under anesthesia. So that's the best place to see that one. And then the SAG test, also known as a 90-90 test, and this is a lot of the reason I didn't talk about the straight leg 90-90 test. But if a person has a PCL tear, what happens is you can take that knee and set it up like this. You really need to take both knees up and put them together and hold up like this right here. And what you'll see is the tibia of the affected knee will literally sag down. It'll have this big sulcus right here. And that's because the tibia is not supported posteriorly, and so the slack falls. All right, any more on the knee?
Is it on there? Did he do that?
Ah, yes, thank you very, very, very much. Okay. The meniscus has a couple of tests that we want to talk about. Number one is McMurray's. And what they do is the examiner will take the knee and they'll flex the knee up, and then they kind of do this little thing where they kind of push and internally rotate the femur, and then they straighten the knee. And what that does is that torques the lateral meniscus. Same thing is they'll externally rotate the femur and straighten the knee. and that will torque the medial meniscus. But the one that I think you'll see, and what I have seen, flip over prone, is this one right here. It's called a Apley's compression and distraction. And what the examiner does is they take a flex knee, and if the arrow is pointing down, remember the menisci are pillars on top of the tibia. That's literally where they attach. And so if I take this and I compress down and then I rotate, if there's a torn meniscus, that test is going to be extremely positive. Another one, Thessaly's test, is very similar to that. It's just done in weight bearing. The patient will stand on the affected knee, they'll flex it, and then they'll rotate over the top, right? And so it has a very high sensitivity and specificity as well. But this one right here, I think, is kind of the one that we look at as being premier.
Are you looking for pain?
Yes. You're also looking for clicking. Menisci are just really common to click and catch and lock. And we'll get into that later. One other, go ahead and flip over for me, that you can do for a meniscus, if you were so inclined, is you can just take that dude and do this right here, terminal flexion. If they have a torn meniscus, terminal flexion almost always lights them up. So you might keep that in mind too. But again, think about it. You're taking those two pillars that are attached to the tibia and you're just basically forcing everything on top of them. Because as the knee comes down, right, what happens is the femur, those big condyles just press into that. And so as that happens, they just kind of press even more into those two pillars of cartilage. And honestly, I would pick that over the other two. If terminal knee flexion hurts and they have catching and locking, they have a meniscus tear. Ankle. Let's do the ankle real quick, and then I'm going to let you guys play with these. All right, so the ankle. Only a couple that I really think you need to focus on. Thank you for being very honest about ligaments. Those of you who've said to me, man, I struggle with ligaments. Anterior talofibular. And we're going to cover some ligaments, therex too. It literally sits right here on the front of the ankle. It's the most commonly injured ligament in the ankle. Just north of that sits the anterior tibiofibular ligament. So it can be very daunting to a student. What I want you to focus on, though, is that talofibular. It's the number one. And what we know is that when it is injured, and most of us in here, if you have an ankle injury in your past, you probably have 10 ankle injuries in your past, because that's really what happens is you don't just get one, you get a bunch. And like pretty soon you're just like, well, I just popped my ankle again, you know, or roll my ankle, however you want to say it. If you played sports, that was you. You come in and I would take you and I would perform here is that word again, anterior drawer test. And the way you do an anterior drawer, we won't take your shoe off just for time, is I literally cup the heel. Come down here for me and let me do it correctly. Come on down and just let your legs lay over. I literally cup the heel. I stabilize the tib. And as I do that, I'll pull forward. Woo! Feel that little junk in there? You ever rolled that ankle before? A couple times, maybe?
Many times.
Okay? And that's probably a little arthritis, to be honest with you. And so I'm just pulling, right? And I'm seeing if that ligament stops, because that's what it does. There's another one. Remember, we talked about this, I think, last week, where I said, okay, here's the ATF, the anterior talofibular, and then down here is the calcaneofibular. It's called the talar tilt. And what you do is you use the foot as your fulcrum, or your lever, I'm sorry. Your thumb is the fulcrum, and I stabilize here, and what I'm doing is I'm seeing if I can tilt that talus in the mortise. And that's just another name for where the tibia and the fibula come down and basically fit over the talus, right? And that's the actual ankle joint. And so what I'm doing is I'm taking that talus and I'm going like this right here with it, and I'm seeing if the calcaneofibular ligament is intact. And if it is, it won't let that move very far at all. So again, what structures are we testing? You just kind of think about, this is what I'm testing. This is what I'm testing. Am I looking for pain? Am I looking for this tissue to be intact? Am I looking for this tissue to be tight? Right? That's what they're asking. Does the student have a appreciation for this, and this? That's all you gotta do.